every version of Teams.
Amazing.
How does
Yep.
that look?
Great, thank you.
Okay. So we don't have to go through the objectives again. This is the slide that I just was on. And so are you seeing the full screen?
Yes.
Yes.
Okay, good. All right. So in Ireland so far, a lot of the research has tried to focus on the benefits of the PA on the multidisciplinary team. So some of the outcomes through this research has demonstrated the continuity of care, which is a huge piece, especially in this health system here. Most of the PAs are working in hospitals, and that is a continuity of care when you have rotas with junior doctors constantly going every 6 months. The PA seems to be the glue on the team, and that is something that we try to promote. The flexible scope of practice, I think that was something that was demonstrated very well during COVID, when on one Friday you had a PA working in orthopedics, and then on Monday morning they were in a medical unit caring for people with COVID. So that flexible scope of practice, and then complementary to the PA team is complementary to the medical team is another bit of research that has helped to clarify the role. So as you know, PAs or clinical officers or advanced practice providers, however you want to call them, are a global profession. I don't think that these numbers are absolutely up to date, but they're pretty close. And you can see that there are many countries that have adopted this particular role. And so it's pretty exciting. I always talk about my father, when he was alive, he always, when I was turned down from every PA program that I tried to get into when I was a young graduate of I had completed my undergraduate degree and was not able to get into a PA program on my first or second attempt. And my father told me to give up and just go to nursing school, which is not meant to be a criticism or minimalization of what nurses do. However, he saw someone who was quite determined and not willing to give up. And just before he died, he told me how grateful and proud he was that I didn't take his advice because he, in his old age, had come to depend on so many of the PAs that were taking care of him in every office that he seemed to frequent, whether it was his GP or his cardiologist or his urologist. They all seemed to have PAs, and he was so proud to tell them that his daughter was one of the first. So here at RCSI, I can tell you a little bit about, we're relatively new. 2015 was the approved pilot from the Department of Health, and our educational model is very similar to what you would find probably in the UK and the United States. It's a 24-month full-time program that takes place after an individual completes their undergraduate degree. In Ireland, they must have a level 8 science degree, so we do not take people from the arts. And that was specifically something that the Department of Health felt was an important piece, because the rapid and accelerated nature of PA training requires someone with a very strong foundation in health sciences or biomedical sciences. Most of our students do have previous healthcare experience, and that doesn't mean we're taking folks from other professions. It just means that many of them have maybe put themselves through undergraduate working as healthcare assistants, or they might have been paramedics or emergency medical technicians. We do have some nurses. We've had some physios. We've also, who else have we had? One pharmacist, but he dropped out. So we have not a very large class, only anywhere between 13 and 15 students per year, which is very small. However, one of the things that is terrific is that we have now worked with the health services executive, which is the HSE, which is the healthcare provider here in Ireland that works alongside the Department of Health. So they're the clinical service provider, and they have agreed to help us expand the program. So in January, we'll have our highest intake ever with 31 students. And this is primarily through scholarships that the health service is providing in exchange for a service obligation to work in the health service upon graduation. And for 2 years of funding, they will require graduates to work for the health service for 3 years. So it's almost a 1.5 year obligation for each year of funding. We have a very, very heavy clinical placement curriculum. So our didactic, which is our preclinical curriculum, really is very accelerated, and it's 8 months from January through August. And then all of our students start their clinical placements in September. And then throughout their placements for 15 months, we have tutorial days that we augment their clinical learning. And one of the things that we just adopted, which I think is pretty exciting, in this past January, we decided to put the program not so much online, but we have now a hybrid option where anyone in the country can enroll in our program, and they only have to come to campus twice a month. And then all of their clinical placements are in their home communities. So this is a way for us to meet the workforce demands across the country and not just focus on Dublin, because as you probably know, Dublin has a high provider to patient ratio, and the needs are not as great, although we have, I'd say, about 60% of our graduates working in Dublin, but we are really, really trying to get them out to the West. So we have right now 6 students enrolled in the hybrid, and in January we'll have another 15 enrolled in the hybrid. It's the exact same program. All the lectures are streamed live, and so students are not allowed to work during the program, and they have to be online, engaging in their learning Monday through Friday, just as if they were on campus. And the fun thing was that we outfitted the classroom with cameras that give the students that are online the feeling of being actually in the classroom. So it's all about where you position the cameras in the classroom to replicate the feeling of being on site. So it's great, and the students love it, and they are just so cohesive as a group. It's remarkable. So it's really one of the things from COVID that we sort of decided we needed to do if we were going to grow this profession outside of Dublin. The Irish Society of PAs is the member organization that serves to help essentially legitimize the credential of the practicing PA here in Dublin. They wrote the national exam, they administer it, they monitor CPD credits, they establish the policies related to participation in the managed voluntary register. This is almost identical to what they do in the UK. And this is the precursor to regulation. So we're really working quite hard right now to have the Irish Medical Council be the regulator. But as you know, in the UK and other jurisdictions, things take time, and it's very, very frustrating for the people who are actually on the ground working. But the Irish Society of PAs is the national sort of representative group for the PAs in Ireland. And we only have 62 PAs in Ireland. We have another 13 that will enter the workforce in January. So we're slowly creeping up, but hopefully before I leave, we'll break 100. And the consultants in Ireland, they just love PAs. They are so, so happy that we are training them. And I think that's more or less tied to the fact that many Irish physicians and surgeons, many of them go over to the US for training. So when they come back to Ireland, they say, why don't we have PAs here? So as you can see, the feedback we get from consultants is very, very strong. And we just had our first annual conference of the ISPA last 2 Saturdays ago, and we had a very, very strong representation from consultants. And it was really great to all be in the same room together and looking at the impact PAs have made in such a short period of time. This is just a quick little summary of some of the articles that have, sort of been in the press around PAs in Ireland. And as I said, we are not regulated. We are working with the HSE right now to get the job description written, to get the pay scale agreed upon. We're benchmarking it against other professional groups that have perhaps similar responsibilities. And we are hopefully going to be able to get that professional grade finalized by next year, I think. So we're working, like I said, we're working on the scope of practice, the job description, the definition, all those fun policy things. And this was just a slide that describes the PA conference that we had a couple of weeks ago. And lots of research. We feel as if the only way to really legitimize the profession and really get the word out there is to publish. So we've had a pretty active research agenda, and we continue to do so. We had a Fulbright scholar from the United States with us all summer who does health workforce research. And so we're just about ready to finish the data analysis on that particular project as well. So this next section describes some of the work that I've done in Rwanda and how it got started. So I was lucky enough to be part of a delegation that went to Rwanda with other members of the faculty of the School of Medicine at George Washington University in I'd say like the early 2000s. And during that time, we did a lot of work on looking at the capacity for the educational system to produce health professionals. And out of that work, I was able to get a Fulbright position in Rwanda to specifically develop the curriculum for the clinical officer program at the University of Rwanda. So in 2012, this program was launched, and it accepted their first class of students at the Kigali Health Institute, and then that went to the University of Rwanda once that institute merged with the University of Rwanda. And in 2020, I've gone back to Rwanda a number of times, but in 2020, I went back there because the Global Clinical Officers Association, that is essentially the largest representative professional organization of clinical officers in Africa. And they held a conference in Rwanda, at which time I met with the dean of the university, or he was the chancellor, excuse me. And we had a great talk about where PAs or where the clinical officers were, because they were having some difficulty with registration, regulation, wider acceptance across the health system. And I can get into some of the details about that maybe during our discussion, but as Rwanda was sort of emerging from the history of the genocide and trying to sort of scale up their workforce to meet the needs of a very large and expanding population, one of the things that there were a lot of universities coming into the country offering to do X, Y, and Z. And what happened was, I think the clinical officers, we tried to embed it into a local institution and let it flourish in that regard. But when you have Harvard University and Paul Farmer coming into the country promoting other types of workforce development, unfortunately, we were somewhat overshadowed, and unfortunately didn't have a lot of money to develop lots of in-country presence. And it's very, very hard to break through some traditional workforce structures. Let's just put it that way. So in 2021, a young man by the name of Nathan Rutatina, who is currently pursuing a PhD outside of Rwanda, but he is a clinical officer. He was the president of the Rwandan Clinical Officer Association. He's a staunch advocate, and he's really quite a visionary guy, and decided that in order for the profession to really grow in Rwanda, he's going to have to hone his research skills. And so he's now pursuing a PhD. He'll plan to go back into the Department of Health where he was working as a clinical officer, and really help to elevate. And his hope is to elevate the profession across the health system. Some of the workforce numbers in Rwanda are not that great. Despite new schools, new medical programs. This is an old map, but it was 2018, but it was put out by the Department of Health in Rwanda. The country has 13.5 million people. When I was there, and this is many, many years ago, after the genocide, there were 300 doctors in the country, and the population was 11 million at the time. So now we've got a population that's still growing. The goal is to have a one physician to 7,000 population by 2024. I'm not sure they're going to meet that goal, but in this map, you can see that as most countries struggle with rural workforce issues, the counties or provinces that are colored in red or orange are the worst, and the ones that are in green are the ones that are in Kigali or the center of the country, and they tend to have a higher proportion of doctors in those areas. So the clinical officers in Rwanda right now, they're a small group. Many of them are not very happy with the lack of progression of the profession. Many of them work in community health roles. Some PAs, some clinical officers work in the prison system, and they're doing a lot of work to, I'd say, improve the quality of care that inmates get in that particular health system. But we are, and I did go on the website today. The University of Rwanda still is offering the program. They might have paused it for a few years, but they still are advertising it. So what has really gotten some strong press is the university that's highlighted on this slide, and the University for Global Health Equity. So I'm sure some of you probably have heard about this, and they offer a number of degrees, including training physicians to work in rural areas. And this is embedded in the ethos of the university itself, which is not located in Kigali, but it's located elsewhere. And many of you probably are relatively familiar with this. Let's see, she was I believe she was the Minister of Health formerly, and she went on to work with Paul Farmer to launch this new university in Rwanda. So now I'll just talk a little bit about the PA profession in the United States, which is something I'm much more familiar with, but still, or I should say much more experienced with. So it's the decades of growth for the PA profession have been quite remarkable. But we're a large country. There's a lot of capacity for growth. And the three gentlemen on the bottom left-hand corner of the slide are the first PAs that were trained at Duke University in 1967. And the PA profession has had remarkable growth, much like the UK. The metrics between 2016 and 2020 showed almost 30% growth. Right now, we have 168,000 or more certified PAs. I think they graduate about 8,000 PAs a year in the United States. And I think in the next couple of years, it's probably going to grow to 10,000. So it is one of the fastest growing professions in the United States. So these are key events that happened in establishing the profession in the United States. And I think it's a good slide to help us think about what are the enabling factors that have to be in place in order for this to really take off. So the professions organization. So these are the accreditation bodies, the professional body that represents the clinicians, the professional body that represents the educators, and the professional body that regulates the profession through the national exam and recertification. So those were all established soon after the first PAs were trained in North Carolina. And then these formal educational programs were accredited mostly through the AMA, which is the American Medical Association, and that has transitioned to a freestanding organization right now, but they were the initial ones. And that, demonstrates the close alliance, and I think you see it in the UK as well, the close alliance between medicine, the profession of medicine, and PAs. The certifying body, as I said, was 1973. The federal funding, which really helped grow the profession in the United States, and it was really not just for PAs, it was at a time of social change when we were seeing lots of new professions grow grow into the workforce. So that's, I think, what Health Education England was doing when they were looking at anesthesia assistants and a variety of other folks besides the physician associates. But in the United States, PAs grew out of this social change movement, and it included nurse practitioners. So nurse practitioners and PAs pretty much started at the same time. We had lots of research in the early days showing good acceptance by patients, physicians, and other health professionals. And that's always key if you're going to try to innovate and insert change into a very structured, somewhat resistant system. And then we got the formal endorsement from the American Medical Association soon after the first graduates came out of Duke. And so that really encouraged the state medical boards in the United States to pass enabling legislation, which is necessary for PAs to practice in the United States. So it's not one whole body that looks at organizing and regulating PAs. It's a state by state jurisdiction. So there's a fellow by the name of Gene Schneller who really was one of the first folks to really look at what the role is of the PA and how do you sort of research it and how do you describe it to people. He was a medical sociologist, and he promoted this notion of negotiated performance autonomy. And it's interesting because some of the research that I just finished this summer looked at the issues of trust across the medical team, and how this, performance autonomy that's negotiated between a consulting doctor and the PA, or the GP and the PA. This is really sort of what we look at as the sort of nuanced role of the PA, but it does capture, I think, the central elements of the PA and the doctor relationship. And it's really the underpinning, I think, one of the strongest underpinning for our theoretical base as a profession. This is a recent infographic that was put out by the NCCPA. That's the group that regulates physician associates. I shouldn't say regulates, they certify. So you have to go through the National Commission for Certification of PAs. You have to go through them. You get your certification by passing an exam. They used to require us to take an exam every 6 years. They've now modified that to 10 years. And you can either take the exam or you can do a continuous assessment over the course of 2 years. Every quarter, you get questions sent to you and you have to answer them. And you can use resources. So it's a more, I'm actually doing that particular model myself now. I don't really like going into a computer center and sitting there for 4 hours taking 300 multiple choice exams every 10 years. So now I just do my 20 questions every quarter and I'm happy. So But you can see here, the number of people that are certified, the number of professions that are, popular, lots of surgery, lots of general practice. Dermatology is huge in the United States. As we see an aging population, seems like everybody has to go to the dermatologist now. So the PAs, and it's actually one of the things about PAs I think that's really fascinating, in that very good at procedures. So they meld nicely with the dermatology practice. But anyway, I'll get off that. So what are some of the global sort of lessons that I can share with you? So there needs to be a really strong rationale for why you want to start this new profession and insert it into the healthcare team. I thought I had a really good one in Rwanda when I was asked to go there and help write the curriculum, but I also wasn't able to stay in the country long enough to be that force for change. And I wasn't Rwandan either. So I really hoped that it would be a more organic sort of growth, but a lot of factors came into play. But anyway, you need to have a strong rationale. There needs to be really strong physician support. And actually, this notion of physician champions is something that came out of my own research that I did in the late 90s, early 2000s. And I did cognitive mapping for the early PAs that were part of the sort of, I'd say, the first 20 to 30 years of the growth of the profession. And some of the emerging themes that came out of it was this notion of a physician champion. So it just goes to show how influential our physician colleagues are in breaking down barriers. The dependent practice stance does decrease the threat to physicians that are sort of somewhat wary of the new professional group. So when we talk about, my primary consultant is Dr. So-and-so or Mr. So-and-so or Mrs. So-and-so, that is really something that helps people with resistance to change to feel less threatened when we know that we're working closely in an independent supervisor role. We have to get key stakeholders to really sort of get on the bandwagon, if you will. And this includes not only physicians, but patients, other healthcare providers, nurse practitioners, physiotherapists, but really it's the health policy people and the people in health economics that can make and I'd say that that's one of the other key factors. Can we make a strong economic case as to why this cadre of health professionals is going to be critical to the workforce? And then this notion of the legal foundation must be established and defined early on. So that's part of what you look at for regulation. A word on the media attention that's coming out of the UK, unfortunately. I saw this on Sunday as I was reading a paper when I was in Wales. And this was from the Sunday Mail, I believe. And it's really unfortunate, some of the sensationalism that's going on right now with some of the negative or the unfortunate outcomes that have been promoted across the media and on social media as well. But I wanted to inundate this man's email box with letters from students and consultants and really maybe have him have to report on something that's good as opposed to something that's bad. This slide just has the different specific PA organizations that if you're interested in learning more about them, I included them.